Yeah. Very good afternoon, one and all present here. Myself, Raghavendra Pranit, on behalf of Biocon Biologics, welcomes you all for the today's webinar. Now, I would like to invite today's our speaker, Dr. Praveen Makker, sir, who is one of the leading diabetologists in Sri Ganganagar. Currently, he is working as a consultant physician at Shinga Hospital, Jawahar Nagar, Sri Ganganagar. Doctor is having more than 22 years of clinical experience. Along with the clinical experience, doctor is also experienced in the clinical trials as a primary investigator. Doctor having a numerous publications indexed in national and international journals, like effect of uncontrolled diabetes mellitus on pulmonary functions. Only few are read out, many more feathers in the crowd. Welcome you, sir. Please take over the session.
Good evening, the delegates present in the session. We have discussed the importance of insulins in many of our previous discussions. Today we'll discuss about the timely initiation of glargine kind of insulins, and that also interchangeable glargine, where the blood sugar is uncontrolled and you want to shift the patients to the insulins, and what are the roles of interchangeable glargine? Are they equal to the glargine present in the natural form, or they are inferior or superior to this? Let us start our presentation. As we know, the prevalence of diabetes is continuously raising all over the world, including the South Asian parts. As you can see the maps here, you can see the distribution of diabetes in different countries and in the different part of the world. And you can make out from this that 1 in 11 adults, that is around 90 million, they are living with diabetes in all over the world. The number of adults with diabetes is expected to reach 113 million by 2030 and 151 million by 2045. And that is a very, very large number. We have to be very, very careful about this disease, this deadly disease. Over 1 in 2 adults living with diabetes, they are still undiagnosed. So presenting with complicated diabetic patients in this kind of population is a common entity in the coming era. And one more number is 7,47,000 deaths. They are caused by diabetes in 2021. In US, around $10 billion are spent on diabetes in year 2021. So these figures are frightening. So we have to be very, very cautious and careful while dealing with the diabetes, and we have to make the patients also educated about the treatment and the complications of diabetes. Clinical inertia is quite common in real-world treatment of type 2 diabetes. HbA1c, if you take more than 7, the median time to intensification is around 2.9 years. And A1C at insulin initiation is still around 8.7%, and median time to intensification with insulin 7.1 years. And A1C insulin initiation at 9.1%, and median time to intensification with insulin is 6.1 years. That is a retrospective cohort study of 81,573 diabetes mellitus patients in the United Kingdom using the Clinical Practice Research Data Link database between January 2004 and December 2006, with follow-up until April 2011. That's an old study we are talking about. Let us discuss about the benefits of early initiation of the insulin. If we start the insulin in time or early, there's improvement in the beta cell functions by reducing the glucotoxicity and lipotoxicity. There are beneficial effects in the lipids or lipid profile that becomes better in where the patients are started on insulin early. It also improves the quality of the life, and insulin resistance can be delayed while using insulin early. So these are the 4 benefits provided by the insulin if they are started early. At the time of diagnosis, this is a very interesting point that almost 50% of the pancreatic functions have been lost as soon as the patient is diagnosed. So the diabetes even if it is not diagnosed, is going through in your body and causing damage to your pancreas. It was found that islet function was about 50% normal at the time of diagnosis, and a reduction in beta cell mass of about 60% was shown at necropsy. The reduction of beta cell mass is attributable to accelerated apoptosis. The major factors for progressive loss of beta cell function and mass are glucotoxicity, lipotoxicity, pro-inflammatory cytokines, leptin, and islet cell amyloid. Among the interventions to preserve or rejuvenate beta cells, short-term intensive insulin therapy of newly diagnosed type 2 diabetes will improve beta cell function, usually leading to a temporary remission type. This is a study with the in 2007 by Bernardo and Wasserwerk. What is the need for early and timely insulin initiation? Type 2 diabetes mellitus is characterized by early progressive insulin deficiency. No oral therapy alters the decline in beta cell function. Poor glycemic control is an important driver for diabetes complications, and early insulin therapy is physiologically intelligent, will provide long-term health benefits for type 2 diabetes patients. And early insulin therapy overcomes beta cell exhaustion. Clinical inertia, non-compliance, and adverse effects often result in a prolonged glycemic burden for individuals with type 2 diabetes receiving oral anti-diabetic agents. Early insulin initiation can help overcome the glucotoxic effects of hyperglycemia and hence facilitate beta cell rest to preserve beta cell mass and function while also improving insulin sensitivity. Early addition of insulin prolongs the beta cell function and promotes metabolic control. As you can see, early initiation of insulin, deaths related to diabetes are down by 21%. If you down the HbA1c by 1%, deaths can be down by 21%. Microvascular complications, they are down by infarction, down by 14%. An impact of intensive therapy for diabetes. Summary of major clinical trials. You can see the different trials: UKPDS, DCCT, Record, Advanced, and WAD, and you can see the microvascular complications. They are decreased. The CVD incidence is decreased, mortality is decreased, and all the trials, they are showing either the decreased trends of these complications or the equivocal. ADA standards of care 2022 say consider insulin as first injectable if blood glucose is more than 300 milligram per deciliter or A1C is more than 11%. So there is evidence of ongoing catabolism, that is weight loss. Other symptoms of hyperglycemia are present. Initiation with basal insulin alone is the most conventional initial insulin regime and can be added to metformin and other oral agents. It can be started at 10 international units a day or 0.1 to 0.2 international units per kilogram a day. Patients on GLP-1 receptor agonist, if the add basal insulin if A1C is above target with GLP-1 receptor agonist. For patients on GLP-1 receptor agonist and basal insulin, consider FRC of both, but not maximum dose of insulin in FRCs. The ADA standards of care 2019 suggest that insulin should be started if blood glucose is more than 300 milligrams per deciliter. RSSDA guideline on initiation and titration of basal insulin. You can see the initiation of basal insulin. If A1C is less than 8%, it should be started with 0.1 to 0.2 units per kilogram. If A1C is more than 8%, should be started with 0.2 to 0.3 units per kilogram. And how it should be titrated? Every 2 to 3 days to reach glycemic goals. Fasting glucose if more than 180, add 4 units. Fasting glucose if 140 to 180, add 2 units. And fasting glucose if more than between 110 and 139, add 1 unit. And to manage the hypoglycemia, if blood sugar is less than 70, reduce by 10 to 20%. Or blood glucose less than 40, reduce by 20 to 40%. Affordability is a big factor in our country where we are living in the developing country, and the patients who are here, who cannot afford that expensive medicine. And so affordability is an issue where patient can accept the insulin if it is affordable to them. You can see the rise in insulin price and its impact for millions of people living with diabetes, including all individuals with type 2 diabetes. Access to insulin is literally a matter of life and death. The average list price of insulin has skyrocketed in recent years, nearly tripling between 2002 and 2013. The reasons for this increase are not entirely clear, but are due in part of the complexity of drug pricing in general and of insulin pricing in particular. So as you can see, the graph, high price in insulin had made the drug out of reach to many patients. Tens of thousands of people with type 1 diabetes who need insulin to survive, and more than 30 million with type 2 diabetes who require insulin do not have access to a reliable and affordable supply. 30 million. 86% of people with type 2 diabetes are unable to access the insulin they need. This is a great number. 63% of households in low income countries are unable to afford insulin. So this is the data which shows affordability as well as the effect of insulin. They both play a role, but as if the patient is not affording or the drug is not affordable to the patient, even a good drug cannot be used very frequently. FDA has approved first interchangeable biosimilar insulin product for treatment of diabetes. USFDA approved the first interchangeable biosimilar insulin product indicated to improve glycemic control in adults and pediatric patients with type 1 diabetes mellitus and in adults with type 2 diabetes mellitus. Approval of this interchangeable insulin glargine can provide patients with additional safe, high quality, and potentially cost effective options for treating diabetes. An interchangeable biosimilar product may be substituted for the reference product without the intervention of the prescriber. Switching versus interchangeability, what does it convey? Switching, a practice wherein a prescriber decides to exchange a biosimilar for another medicine with the same therapeutic intent. And interchangeability, changing one medicine for another, one which is expected to achieve the same clinical effect in a given clinical setting in any one patient. We'll discuss about the Biocon's insulin glargine. These are the global trials done in different countries. 7 clinical trials in 1915 patients in 20 countries were performed on Biocon's insulin glargine. INSTRIDE 1 study, non-inferiority study to compare the efficacy and safety of Biocon's insulin glargine with reference insulin glargine in type 1 diabetes mellitus. Insulin glargine global phase 3 study in type 1 diabetes mellitus, efficacy and safety of Biocon glargine compared with reference insulin glargine in patients with type 1 diabetes, the INSTRIDE 1 study. The objective was to determine whether Biocon glargine once daily is non-inferior to reference insulin glargine once daily when administered in combination with mealtime insulin lispro in patients with type 1 diabetes mellitus. Study design was a multi-center, open-label, randomized parallel group comparative phase 3 study. The sample size was 558 type 1 diabetes patients with HbA1c less than 9.5% at screening. Population type 1 diabetes mellitus, 18 of patients of 18 to 65 years treated with once daily insulin glargine for at least 3 months. It was screened for 4 weeks, run for 6 weeks, and 1:1 ratio of Biocon's insulin to reference insulin glargine for 52 weeks, and follow-up was for 4 weeks. After a 4-week screening period, patients began a 6-week run-in period and were titrated with reference insulin glargine and insulin lispro as needed to ensure good diabetes control as determined by the investigator. Insulin glargine was administered by a subcutaneous injection at a dose adapted to patients' blood glucose levels. Dosing of Biocon glargine was guided by SMBG assessments as suggested by the reference glargine dosing algorithm. Titration was performed first for insulin glargine, then for insulin lispro. The dosage of insulin glargine was adjusted so that patients attained a fasting prevented glucose of 70 to 130 milligram per deciliter. After insulin glargine was titrated to the optimal dosage, the dosage of insulin lispro was adjusted so that patients attained the lowest postprandial blood glucose of less than 180 milligram per deciliter. Mean standard deviation for the actual HbA1c and actual fasting fasting plasma glucose by visit and treatment. HbA1c stabilized at all time points from baseline, and actual fasting plasma glucose by visit and treatment, you can see the chart. The conclusion, the upper 95% CI limit for mean change in HbA1c at week 24 indicated, and reference insulin glargine similar at weeks 24 and 52. There were no statistically significant differences in actual HbA1c profiles between treatment groups observed over time. Levels of HbA1c in patients were receiving MYL150 ID and reference insulin glargine decreased during the running period of the study. Both basal and bolus insulin dose levels did not differ between groups. Rates of hypoglycemia and other adverse effects were comparable between two groups. INSTRIDE 2 study was performed for non-inferiority study to compare the efficacy and safety of Biocon's insulin glargine with reference glargine in type 2 diabetes mellitus patients. Objective was to determine whether biosimilar insulin glargine once daily is non-inferior to reference insulin glargine once daily when administered in combination with OADs in patients with type 2 diabetes. Study design was a multi-center, open-label, randomized parallel group comparative phase 3 study in patients with type 2 diabetes taking oral hypoglycemic agents. There were total 560 type 2 diabetes patients, and the population was suffering from the diabetes type 2 for at least 1 year before screening, and there should be stable dose of an oral anti-diabetic agent for 3 months before screening. Either insulin naive or non or insulin glargine once daily at a stable dose for at least 3 months before screening. These were the endpoints: screening for 4 weeks, ratio 1:1, reference insulin glargine for 24 weeks, and follow for 4 weeks. The primary endpoint was change in HbA1c levels from baseline to week 24. Upper limit of the two-sided 95% greater than 0.5% at week 24. To establish the non-inferiority of biosimilar insulin glargine to reference insulin glargine, a repeated measures analysis employing a restricted maximum likelihood-based mixed effects mode approach was used to produce a 95% confidence interval for the difference between biosimilar insulin glargine and reference insulin glargine. The mean actual HbA1c over time, as you can see, biosimilar glargine mean change in HbA1c baseline to week 24, that was 0.60. LS mean difference between two groups, that was 0.06%. The reference glargine also shows 0.66. So non-inferiority margin upper bound of 95% CI for mean change was 0.4%. At week 24, the mean standard deviation dose of daily basal insulin was 0.366 unit per kilogram and 0.377 units per kilogram in the biosimilar insulin glargine and reference insulin glargine group respectively. For patients who were insulin naive, the mean ST increase in daily basal insulin dose from baseline to week 24 was similar to the biosimilar insulin glargine and reference insulin glargine groups. And these are the conclusions for INSTRIDE 2. Mean change in HbA1c from baseline to week 24 was 0.60 and 0.66% for Biocon's glargine and reference insulin glargine respectively. Results demonstrate that biosimilar insulin glargine is non-inferior to reference insulin glargine in patients with type 2 diabetes. Changes in fasting levels from baseline to week 24 were similar to both groups. Rates of hypoglycemia and other adverse effects were comparable between two groups. INSTRIDE 3, when we talk about to assess, it was done to assess the efficacy, insulin dose, safety, and immunogenicity when people with type 1 diabetes mellitus switched between Biocon's insulin glargine and reference insulin glargine. This was the study design, and this was the type 1 diabetes mellitus patients who completed INSTRIDE 1 study and are on reference insulin glargine 52 weeks. In arm A, there are Biocon's insulin glargine plus Lispro. Switching sequence was from Biocon's insulin glargine plus Lispro to reference insulin glargine plus Lispro to Biocon's insulin glargine plus Lispro. It was assessed at 12 weeks. Each and total for 36 weeks. And end of trial visit was at 36 weeks and follow-up was at 40 weeks. The results were the change in HbA1c from baseline to week 36. Change in HbA1c from baseline to week 36 Biocon's insulin glargine, that is switching sequence, was equivalent to reference insulin glargine, so the results were almost the same. Overall incidences of any hypoglycemic events were comparable between the two sequences. No severe hypoglycemic events occurred at any time point of the study. Anytime hypoglycemia events were comparable in both the sequences throughout the study. This is immunogenicity data, equivalent efficacy, safety, and immunogenicity, demonstrating that patients taking reference insulin glargine can safely switch to Biocon's insulin glargine. Timely initiation of interchangeable glargine makes a huge economic benefits to the patient. Patient A, who was on reference glargine, when shifted to interchangeable glargine, you can save at least 24,000 of rupees in a year, in 5 years, when he's shifted to the other glargine. Biosimilar and its health economic impact. Challenges were reserved for patients to afford. Move towards affordable and optimal therapy if it is affordable. Late insulinization, timely insulinization in interchangeable glargine. Rise in complications, reduce morbidity and mortality if it is started early. And rising economic burden on the insurers, government or NGOs. Healthcare cost saving is there with biosimilars. So better health outcomes if biosimilars of glargine are used frequently and commonly in the patients of uncontrolled diabetes. So one can shift easily to the biosimilars if the patient cannot afford the glargines, other glargines. Thank you for your patience listening. The take home message is that you should initiate insulin early and you should choose your insulin wisely, which is easily acceptable, easily administrable, and give economic benefit to the patient also, so that he can use it for a longer time and get better benefit by using insulin. Thank you.
Thank you, Doctor, for accepting Biocon's invitation as a speaker and delivering such a valuable insights and enlightening all the delegates. Last but not the least, I want to thank each and every delegate who attended today's session by taking out their time and made this session successful. Thank you, everyone. Thank you so once again.
Thank you.